Hello, everybody, and welcome to our webinar for this month. Really excited for this topic. I think this is one that we're seeing a lot of in social media. We're seeing a lot of influencer chatter about it. So definitely worthwhile to sort of talk deeply about the data and what we do and don't know. I am thrilled to be joined tonight by Dr. Jane Benning. And Jane, will you introduce yourself and tell us a little bit about your background?
Oh, thank you so much. It's a great pleasure to be here. I am board certified OBGYN for many, many years. I was in a position to decide to give up obstetrics early in my career when I transitioned from Los Angeles to Orange County, and I stopped doing OB in my early 40s. So that allowed me to have a GYN practice, and I eventually developed a concierge practice. So it was really fascinating. I got to know my patients really well. I also have some sex therapy training actually from the Neuropsychiatric Institute at UCLA. And what ended up happening was I developed a real finesse for how to, I call it tinkering with women's hormones to help them feel better. But I always stayed in the more or less what's FDA approved, what does the information tell us? None of these way out situations that you see so much in various conferences. And
hmm
so I always tried very hard to stay within the guidelines of what seemed to be healthy, safe, and have some proof behind it. But I was also aware of the controversies about the Women's Health Initiative and some of the misinformation. And at the time, I was prescribing hormones for a lot of my practice, and that continued. So I've just always enjoyed it's kind of more of a psychiatric way to approach gynecology, which I think if I had not, I could have gone into psychiatry, but I think I'm really glad I chose OBGYN because at the time I liked all the surgery and delivering all the babies, and
hmm
I was able to create a practice that kind of was more suited for my personality. I retired a few years ago from my private practice, and at the time, there were people that I'd been seeing for 30 years. And I moved out of the area too. So it was kind of like all of a sudden I was retired, but then COVID hit, and it was a good thing I had retired before that. But
Yeah.
anyway, so it's great to be in a situation where I can do the hormone management and get back into the field. I'm really happy to be doing that.
Yeah. And thank you for that introduction. And I was going to say, you mentioned having a lot of psychiatric background and things like that. We sometimes joke at Genève that we should call ourselves gynecologists because so
Yes.
much of what we do does involve mental health and helping women through large transitions in their lives.
Mm-hmm. Oh,
So
definitely.
today we're going to address the use of menopausal hormone therapy in women with DVT risk. And, I really wanted to address this because I don't know about you, but I see a lot of patients coming to me who have risk factors, who have histories of DVT, and they're telling me, no, I watched this video online. They told me it's fine because it was provoked. And I tell a funny story. I had one patient who came to me and said, no, I saw the influencer. She said it was fine because my DVT was provoked. And I said, well, what provoked it? And she said, birth control pills. I'm like, okay, let's walk through that and why
Right.
that might not make sense. Um, but I also wanted to do a deep dive for myself because, like anyone, I can be out of date on the literature. So I really wanted to take the time to read through all the literature, or at least what I could find, and really understand, am I missing something? Is it actually safe? What do we know? And that's sort of how this webinar was born. I do want to start with some important basics, which is tonight we're going to talk about transdermal estrogen and DVT
Mm-hmm.
risk. I'll
Yeah.
mention a few things that we know about oral estrogens and we'll talk about it a little, but we know that oral estrogens increase DVT risk and we know that it increases more for women who have risk factors. So, really, if you're ever considering using estrogen in someone who has any of these risk factors, it should be transdermal and transdermal only. Um, and we talk primarily about risk of recurrent DVT, but keep in mind there are a lot of different clotting disorders that can be impacted by estrogens. So we're not just talking about DVT risk. We're also have to keep in mind, are we increasing their MI risk? Are we increasing their stroke risk if we're increasing clot risk? So, you know, the data tends to focus on recurrent DVT, and that's what we'll address tonight, but you have to keep those things in mind too.
So I was going to ask you then, could you start with exploring the data around the low risk for clotting with transdermal estrogen in general? Where does this data come from?
Yeah. So it's a great place to start. And there are a few studies that we could look at, but I think the most influential one has been the Million Woman study. And so the Million Woman study is a large prospective cohort study that came out of the UK, and they actually looked at 1.3 million women between 50 and 64. And they were really actually taking women from their national breast screening program and then looking at other um, like interventions and risks that might come along with being that age. And so the women who were in the study, this study did not exclude women with prior VTE, but they didn't specifically ask about it. So there may be some in there. We can't really make conclusions about VTE, high risk VTE patients on this. And they also didn't exclude women with cardiovascular disease. Um, and the other qualification I always make about this study is that this is a white cohort. This is the UK. Ethnic minorities
Hmm.
are vastly underrepresented. Um, So we just have to keep those things in mind when we're looking at this because they didn't give them estrogen. They just looked at who was using it and who was not and what some of their risks were from doing that. And so women who maybe had a prior VTE or women who had significant cardiovascular disease may not have been given it. So the populations may differ in terms of their baseline risk.
Right.
And it really was sort of to look at, well, how does menopausal hormone therapy impact breast cancer risk, cardiovascular disease, VTE, stroke, and other sort of chronic disease outcomes? Um, and it's really, in general, we talk about, yeah, a randomized controlled trial would be better to talk about these risks, but it's really influential because it's just so big, and
Yeah.
represents a huge population. So they followed them prospectively. They had self-reporting of HRT. They compared never users to past users to current users when they did their data. And they were able to stratify versus estrogen only versus combined, oral versus transdermal, and the type of progestogen that was used. So what they found was that overall, oral hormone therapy users had about a twofold increased risk of VTE compared to people who had never used it. And it was about a hazard ratio of 2.0 for oral users and higher for combined users. And we'll talk a little bit about that as well. And the risk was highest in the first 1 to 2 years of use, and then was much, much lower for past users. Um, and I think, you know, it was one of the first studies to actually talk to us about the idea that um, estrogen versus estrogen plus progesterone have different risks.
And that was one thing we were going to also sort
Hmm.
out a little bit, or I wanted to ask you, did it seem
Yeah,
like, was there any discussion of what type of progestogen with, if there were different risks with different
right.
progestogens?
So yeah, we have seen this in other studies as well. And keeping in mind that a lot of our data comes from studies of conjugated equine estrogens plus medroxyprogesterone acetate, we
Hmm.
know that the combination does increase risk. So medroxyprogesterone acetate does seem to increase risk when combined with estrogen to a certain extent. And some of the progestogens do. We have seen in later studies that micronized progesterone may not have that impact, or at least not nearly the detectable impact that some of the other progestogens do have. So, the type of progestogen is not inconsequential. Um, the moral of this big long story is that what they didn't see was an increased risk of DVT or thrombotic events with transdermal estrogen users. Um, and over a very large study, there was no detectable significantly increased risk. And that really, and we understand the biology of that. We understand that the background that oral estrogen definitely has a first pass effect in the liver, and increases clotting factors when it does that. We can detect that difference. And CE does it more than oral estradiol. And then they both, and when we use a transdermal estrogen, we don't really detect that. And that's really that first pass metabolism of those oral estrogens, whereas the transdermal skip that first pass.
Could you just address, there is a discussion about the second pass. Could you
Ah,
clarify
yes.
what the second pass means,
Right.
Rebecca?
So whenever you have something circulating in your blood, it's going to go by the liver, right? But the
Mm-hmm.
difference between first pass and second pass is primarily concentration. So when you take something orally, it goes all of it straight to the liver at full dose. A lot
Mm-hmm.
of it is processed to get it to a very low circulating amount.
Yeah.
When you put it in transdermal, the overall amount circulating is already at that very low level. So even though the liver will see a little bit of it, it's at a very low concentration. And so we really don't, especially with the lower transdermals, don't see any change in clotting factors. But even with some of the higher ones, even at 0.075 or even zero point 0.1, there's not a huge impact on the liver because the overall circulating amount of estradiol is so low.
So really, it doesn't make much difference what dose of, for instance, patch
We don't
someone's
have a
on.
lot of data what dose. I know there's a lot,
Mm-hmm.
I tried to track down where we came by the, oh, we need to stay at 0.05 or below. And, obviously the lower, the less impact you're going to have, but we don't get a huge impact from those two higher patch doses either.
Yeah, well, that's really good to know in case some
Yeah.
people really do need the higher dose.
Yeah, and many women do, especially in perimenopause. I'm sure you've seen that as well. Like when you're used to having the estrogen up here and then down here and then up here, sometimes you need to start a little higher.
Mm-hmm. Yep.
So, overall, for this relatively low risk population, there was really no increased risk. They did see slight increases in risk in women who were obese as they got older. And then what they could pull of people they knew had a prior VTE or thrombophilia, they saw an increase in risk, but they weren't really able to sort out transdermal versus oral in those in this study. So obviously, strengths
Mm-hmm.
of the study, huge sample size, just massive sample size, lots and lots of data. Limitations, observational. We don't know how these women differed before they made the decision to start menopausal hormone therapy. And, the global generalization is not that high. These are white British women, so primarily. So, you know, what I tell my patients is the data like this tells me that in a low risk woman, I really don't think there is an increased risk in adding a transdermal estrogen for clotting over her baseline. But I really don't think we can use this data to speak to that other category, which is women who may be at higher risk. And so we need to look elsewhere for data on that.
And by the way, it just so happens that the white Caucasian population that would primarily exist in the UK, Caucasians do have the higher risk of background thrombophilias, the
That is true.
inherited thrombophilias, whereas I guess
Hmm.
Asian people have almost no thrombophilias and very low penetrance or low percentage of Hispanic people and Black
Hmm.
people and Native
Yeah,
American people have thrombophilias. So at least this population were the group that would tend to have more inherited thrombophilias. Just,
a good point. Yeah, yeah.
you know,
So I guess to move on to the higher risk women, what we should really do is look at, well, what have we got in there, right? Is there data telling us it's safe to use these preparations in these women? And, when I started to go looking for this, I was like, okay, there is not a lot of data here. But other people have looked and really nicely. Dr. Hicks and their study group published a paper in 2025 in Climacteric that did a big systematic review of all of the papers that they could find. So that was where I started. And I always like to qualify a systematic review when I'm reviewing it because there are different ways to do that type of study. There's, hey, I gathered up all these papers. This is what they say, which is basically what we have here. Versus I was able to get enough papers that I can rate them on quality and only take the highest quality papers and combine their data and try to make more assumptions. We don't have that ability here. when they were looking at these papers, there were only one, maybe two, in some cases, sometimes three papers, very small papers on any of these subject areas. So really what we're getting from them is sort of a regurgitation of the results of all these papers, but at least they were all in one place. So it makes the
Mm-hmm.
start point easier.
Yeah. Mm-hmm.
The one thing I appreciated about the paper was that they only used papers where if a DVT happened, it was diagnosed with imaging, not just blood testing. And they required lab testing proof of clotting of any thrombophilias if they were looking at thrombophilias. So we actually have pretty good data in the papers that they were looking at. Um, and I sort of talked about how the actual meta-analysis or systematic review itself is not that strong because they couldn't really quantify the quality of the papers. They did describe the methods of the papers. One of the complaints I have about this particular systematic review is what they didn't describe in each of their subject areas was how many patients were in each of the studies. So I had to actually dig a little deeper to get to that. So let's start by talking about women who have had a DVT in the past. So the papers do not distinguish how that DVT came about. So we can't say provoked versus unprovoked, X, Y, or Z. This is just women who had a previous history of DVT and what happens if they take menopausal hormone therapy. And they only found two studies looking at this. Um, and one was actually a randomized controlled trial, which is great, except it had to be stopped early because there's a randomized controlled trial of oral estradiol and norethindrone versus no use. And they stopped it early because by the time they stopped it, the women on oral estradiol and norethindrone had an odds ratio of 8.5 for recurrent DVT. So that pretty much confirms that oral is not our pathway here.
Yeah, that's pretty striking.
It was pretty striking. The other paper they were able to find was a retrospective cohort study. So it was actually done in a hematology practice for women with previous DVT, and they just looked at were any of these women using hormones. They didn't prescribe it. They just wanted to see if they were using it. So they were able to find some women who were using hormones, and then they pulled a group of controls. And at first glance, this paper looks great. 1,032 people in the paper. But then when you look deeper, turns out 900 plus of them were controls. And in fact, they had 130 women who had used hormones total over the period that they looked at. 103 of them used transdermal, and I guess the other 27 used oral. And even based on that, they were able to say the women using oral had a higher risk of recurrent DVT. So again, that pops up. Of the 103, they did not see an increased risk. Their odds ratio was, I believe, 1.1. Now, that is not a large sample size.
No, it certainly
And
isn't.
it certainly isn't. We don't have any information on how these women's DVTs came about, what their other risk factors were. They weren't able to exclude or talk about whether or not they had thrombophilias. So really, what we don't know is a lot about these women. And this is the best paper we've got telling us about the risk of using transdermal estrogen after DVT. They also, in the meta-analysis, did look at acquired thrombophilia patients and whether they had an increased risk when using transdermal estrogen. And
Could you
most of the
just
studies were
mention
looking at specific mutations. Yeah.
what would you how would you describe acquiring a thrombophilia? Just
Oh,
quickly
so
to
they looked at
remind
inherited
us.
or acquired. So inherited, the factor V Leiden,
Right,
prothrombin gene mutation, all of those.
right.
And then the acquired is something like antiphospholipid antibody syndrome, or something that develops later in life that increases your thrombotic risk. But
Like
APL
a
is usually the one they quote.
like a cancer
Um,
even or
right.
um,
Yeah, something that would increase your
some
clot
other
risk.
systemic disease. Okay.
Yeah, yeah. And there were not a lot of studies to go on here. A lot of them used oral estrogens and showed increased risk over baseline. Um, There was one study done in France that included some women on transdermal estrogen with either factor V Leiden or prothrombin gene mutations, both heterozygous and homozygous, so they weren't able to separate that out. It was published in 2005 in the journal Circulation. There were only 60 women in the study on transdermal, and they didn't seem to have an increased risk of DVT. But again, this is 60 women. So how it makes it very hard to then base your clinical practice on that level of data. There was a recent scoping review similar to this study published in Menopause by Dr. Sobel's group, and most of the same studies are in it. There's just not a lot of data, and their conclusions are similar. It doesn't seem to increase risk, but we have very little data.
It's reassuring at least that it all points in the same direction, even if there aren't
Yes.
a lot of numbers. There
Nope.
doesn't seem to be a lot of conflict about
Mm-hmm.
it.
No, there really doesn't.
So that's, as a person who's not quite as discriminating, I guess, in terms of the validity of the studies,
Right.
to me, that's somewhat reassuring.
Right. Um, so I think the other thing to think about, as we're practicing medicine is what does it mean for us in terms of, litigation? Like if we start somebody who's had a DVT, do we have a leg to stand on if something happens? And I often look to society recommendations for that because I think that's where the lawyers are going to look first as well. Is this within standard of care of practice? And our society's really let us down in this one. ACOG hedges amazingly around this, in the risk of DVT with menopausal hormone therapy position statement, they note an increased risk for women with prothrombic mutations, and that transdermal estrogen is considered low risk, but they never actually bring those two things together and say, well, how do we then manage this group of patients? NAM's position statement on hormone replacement therapy, similarly, they just say there isn't enough data, which is fair. There really isn't. And they also mention the lack of randomized controlled trials in this. The most direct opinion I've ever found is from the European Endocrine Society, but they also contradict themselves a little. Up front, they say that menopausal hormone therapy is indicated if women do not have an increased risk of DVT, VTE, or cardiovascular disease. But then in their section on previous DVT or high-risk condition, they say, with individualized counseling and risk assessment, transdermal estrogen and micronized progesterone might be acceptable. So that's really what we've got. That's sort of the preponderance of data.
Yeah, well, it kind of depends on how symptomatic a patient is too, don't you think?
Absolutely. Yeah, it absolutely does. And I think that, you know, I'd love to hear how you've practiced over the years. The way I approach it in my practice is that I'm very clear with patients that we do not have convincing safety data if they've had a DVT or if they have a thrombophilia. I certainly would never start somebody with both a thrombophilia and a DVT on any kind of menopausal hormone therapy, transdermal or not. I've heard a lot about the provoked DVT, like somehow this DVT gets you off the hook. But what I always tell my patients is, lots of women every day have surgery and do not develop DVTs. So I have to think there's something different about you that might make you higher risk. But
Hmm.
also, we don't know what damage that DVT then does to the blood vessel, which might give you a nidus for a future clot. So if you have had a DVT, provoked or otherwise, I think you are at higher risk. And we know you're at higher risk. So then it really becomes a very complex shared decision-making position. You know, how do we decide? I always try to convince them to start with the non-hormonals. Can we solve your symptoms with something else and avoid this risk? I'm not saying I never do it, but I'm very cautious about it because I think we cannot say it's perfectly safe. How about you? How have you practiced over the years?
Well,
And
I think really I can just think of one particular woman who was highly symptomatic, and I don't believe she'd ever had a DVT, but
Mhm.
she had a known, she had carried, I believe it was like one of the thrombophilias, one of the less
Hmm.
common thrombophilias. And she was able, because she was able to take a very low dose of transdermal estrogen, and I kept really close tabs on her. But that, I would say that was probably the only one that I ever, and she had not had a DVT. She just knew that she had this thrombophilia. And that's actually one thing I was hoping maybe you could clarify for us, since there are maybe 3 to 8% of Caucasian women walking around have a thrombophilia. Some of them don't necessarily know
Hmm.
about it. Would there be something in their clinical history that would help you to be more reassured that just a given random patient coming in to see you, or, seeking your care, how would you
Hmm.
determine if they might have an undiagnosed thrombophilia?
Yeah. So, I ask a family history, definitely.
Mm-hmm.
Does
Mm-hmm.
anyone in the family have a known thrombophilia? Does anyone in the family have a history of a blood clot? Obviously, does she have a history of a blood clot? I certainly take into account pregnancy and oral contraceptive use. So if she's
Right.
gotten through 3 pregnancies and 15 years on birth control pills with no clot, much lower risk.
Right.
Um, you know, all the societies are very clear. There's no role for testing for thrombophilias for
Mm-hmm.
for starting menopausal hormone therapy because the pickup is too low and, you know, it may not actually matter if she's had that normal history her whole life.
Yeah, so those are two real important just parts of their clinical history. Were they
Right.
able to get through or fairly far through pregnancies, and
Hmm.
could they take oral contraceptives without
Yeah.
getting the clot? And those are both pretty
Yeah.
reassuring.
Um, so I'm looking at the Q&A as we go along, and people, please put your questions either in the Q&A or the chat. We'll pick them up both places because we want to make sure we answer questions. Somebody asked in the Q&A, are you talking about the Esther study? And if not, can you comment on generalizing it to a high-risk population? So I did not specifically mention the Esther study. It's one of the big studies that sort of looked at the route of estradiol and how it impacts DVT risk, but it really focuses on it doesn't have a focus on the prior DVT or thrombophilia population. They do look at obesity as one of the high risk factors and sort of generalize from there. But I don't think we can really, it's really hard. All of these big studies are great, but we cannot generalize them now to a high risk population unless they specifically address the population of interest. I don't think it's fair of us to be generalizing that data because it's just not the same baseline risk, right? And as I said, there are other factors we have to consider. So, what I really would love to see is much more data and um, data on patients who are actually high risk so that we can start to look at it. I mean, given the small observational data we have on these high risk patients that doesn't seem to show an increased risk, I think you can make a claim that a randomized control trial would actually be acceptable. Oftentimes when we're designing a randomized control trial, we have to be able to prove that we're not doing something dangerous. The little bit of data we have says it may not be dangerous. So you could probably design that. I don't know who we get to fund it, but we could probably design it and it would probably fly with an IRB, at least in my in my mind. Somebody else asks, somebody with systemic lupus, with lupus who without antiphospholipid issues, is MHT safe? As far as we know, yes. And I've actually had that patient and asked that question to a rheumatologist because I wanted to confirm that. If they do not have the antiphospholipid antibodies and they don't have any clot history, then they are not considered at higher risk.
Well, that's definitely good to know.
Yeah. All right. I'm seeing another question. I have a patient on birth control. Would be adding oral micronized progesterone increase the risk of DVT? No previous history. Great question. Um, we don't know. We don't do that. So we have never studied it. So the answer is I can't possibly tell you. That being said, I actually asked my co-podcaster over at Overreactive and a complex family planning person today that very question because I had a patient who is currently on menopausal hormone therapy, but I really think needs to be on SLIND to suppress her ovulation, but she doesn't want to give up her micronized progesterone because it's doing good things for her brain and her OCD type tendencies and her sleep. And I said, I don't think we have any data on this. And she asked the big listserv, and they said, no, we don't really have any data. Could it increase breast cancer risk? Maybe. We don't know because nobody's ever looked. So micronized progesterone, when combined with estrogen, doesn't seem to increase clot risk. But I don't know what it does with ethanyl estradiol because we don't really have a product that looks at that, right? And I don't know what it does when you add it to another synthetic progestogen. So great question. No answer for you.
That's getting pretty creative to even think of that,
I
frankly.
know. I know. Well, I don't know about you, Jane, but I find sometimes I have to be extremely creative with my perimenopausal patients.
Yeah, you have to go out and just kind of figure out what. And it's so funny to me that that some people feel so much better with micronized progesterone, where other people think you're out of your mind for ever having given it to them because
I know. They feel
they get
awful.
very out of body and they feel like they're,
Hmm.
hallucinating. It varies
And
so
I've had
much.
people who have a paradoxical reaction to it where it makes
Mm-hmm.
depression and all those things much, much worse
Yeah,
and they can't
yeah,
sleep. It's
yeah.
interesting. I was just reading, I was just looking at a paper that was sort of hypothesizing that dose may matter for those things. Like some people react to a very small dose of micronized progesterone with that sort of paradoxical reaction, and higher doses will feel better.
Mm,
But I also always warn any of my patients who've had really severe PMDD that they may be one of those people who has a paradoxical reaction. So just to beware of it.
yeah. I mean,
But
when you consent them for taking it, they think, sometimes you tell them the things that can happen. It's like, that sounds pretty horrible. But honestly, I do tell people for the micronized progesterone, take
hmm
it at bedtime on an empty stomach because apparently
hmm
if you have food, take it with food, it can increase the absorption all of a sudden and give you,
hmm
at least that's the impression I got over the years. And because it
yeah,
can make people drowsy, I just figure it's better to take it at bedtime, and it's certainly better for any of us not to go to sleep right after we've eaten. So,
there you
at
go.
for the night. So that's just kind of a good way to do it. But
Yeah. Although I have had some of my patients who stay very drowsy in the morning move it back.
mm-hmm.
I mean, it
Earlier,
doesn't
yeah,
have that long a half-life, but for some people it seems to hang on. We got
yeah.
another question that said, just to clarify, the high risk definition, having a prior incidence of DVT automatically puts someone in that category. And the data so far does not seem to show that transdermal estrogen increases risk for the average woman, but does? No. So, yes, that's the definition of high risk. So, someone who's got a prior DVT was inherited or acquired thrombophilia. Um, and then that's what I'm thinking of as high risk. There are other high risk factors. There's obesity, age, smoking, other things that increase DVT risk too, but we're not addressing those tonight. In terms of the data, in low risk women, no, transdermal estrogen pretty convincingly does not increase their clot risk. We have enough data to say that. In higher risk women, so women with prior DVT or thrombophilia, transdermal estrogen does not seem to increase their clot risk. But the sum total of data that is telling us that is under 200 women. So, and it's observational data. So at this point, I don't feel comfortable saying we know that it doesn't increase risk. The trend is towards it not increasing risk in them either over their baseline, but remember their baseline is higher. So when I say it's not increasing risk, it's not like it's making them like a low risk woman. It's just not increasing their risk over their already higher baseline. Because anyone who's had a DVT or has a thrombophilia is already at a higher risk of getting a clot. But we just don't have enough yet to say with assurance that it's not increasing their risk. I think more study is needed, but the what we've got does not point to increased risk with transdermal estrogen. I hope that sort
Okay.
of clarifies and answers the question. That was the too long don't read version. So for anybody who missed the beginning, that's all you really need.
Rebecca, could you address for these women that you feel taking any kind of estrogen, including transdermal, is a hard no because of their history?
Mhm.
What kind of results have you had with this new Linkuet? Is
Oh
that,
yeah, sure.
am I saying it right?
Yeah, linquette, I call it.
Linquette.
So I will give a little disclosure. So one of my roles is as a clinical researcher, and our research center participated in the pivotal trials both for Veoza and linquette. So I
Oh.
have a pretty extensive experience with both of these medications. Both of the
Mm.
NK receptor antagonists seem to have pretty robust hot flash relief.
Okay.
And Linquette has slightly better data for also improving sleep, even
Mm.
outside of the hot flash relief.
Mm-hmm.
So, because Veoza only blocks NK3 or neurokinin 3 receptors, and Linquette blocks two receptors, so neurokinin 1 and 3. Um, Both are really reasonable choices for women, and a lot of how we make that decision is really based on insurance coverage or lack thereof, and it's mostly lack thereof right now. The coupons, the accessibility, how they want to get their medications, whether they want to get it locally or with the mail order pharmacy, all of those things sort of play into it. In my experience, women get really robust hot flash relief from these medications. And I have a couple
Mm.
patients now on Linquette, which has been out 4 or 5 months, who do seem to see some sleep benefit from it. What I hear a lot from women when I'm offering them these things is that they're worried they're not getting the other benefits of hormones. And, I think there's a lot of messaging out there that hormones are the great panacea for everything. And I think we need to qualify that with women. Can they help with joint pain? Absolutely. Can they help with brain fog? For some women, yes. Can they even out mood for some women? Absolutely. We do have other medications for all of those things for the most part. The brain fog's the hard one. We don't really have a good medication for that, although getting more sleep absolutely helps with that.
Right.
um, Bone health, yeah, estrogen's just better. These other medications aren't going to help with that, but we have other medications for bone health if that's a concern. Um, a lot of women are convinced still that estrogen has robust data for cardiovascular benefit. We really don't have robust data. I do tell people, starting at the time of transition to menopause, you're certainly not hurting your cardiovascular system. Are you benefiting it? Maybe. But a lot of the data is really old and with conjugated equine estrogens that shows that, and that's not what we're using anymore. And we really don't have that data with transdermal estradiol. So I think managing expectations of what estrogen is going to do for them and talking about risk benefit ratio and saying, hey, if we can make you feel more like yourself with this medication, which does not carry that risk, maybe that's a better first place.
And could you just clarify that so the linquette is not going to be something that increases the risk of venous thromboembolism in
Nope.
someone with thrombophilia?
Nope.
Great.
No, it does not increase venous thromboembolism risk. Both of the medications do have a slight, no, that's not true. Veoza in the studies showed some liver function abnormalities, but they resolved in all the patients. So even continuing the medication, they resolved.
Oh,
Linquette really didn't show that. The FDA has asked us to do LFTs at 0 and 3 months, even with Linquette, despite the studies not really showing liver function changes, because they're worried that as we get more data, we'll start to see it because it's a similar class of drug. But even with that, even with those liver function changes, there still was no increased risk of clotting.
oh, great. And what about, I'm presuming it doesn't help at all with vaginal dryness or the
No,
genitourinary syndrome of menopause.
it does not. But there is no reason we cannot use localized estrogen in women of all risks. So women with a history of DVT, with a thrombophilia, can absolutely have vaginal estrogen and should have vaginal estrogen, just like our breast cancer sisters should be having vaginal estrogen because it's localized and not really absorbed systemically. If someone's really worried, I make sure to use one of the fixed dose vaginal things, so either Imvexi or Vagifem or an E-string, because then at least we know there's a reliable dose. The cream can be a little bit, you can get some systemic from the cream if you're putting 4 grams in there.
Yeah. Well, that's another really good thing to know because that's one of the things that the Linquet will not help with, though. So they'll need
No,
that as an
it really
additional.
won't. It really won't. And,
Yeah.
yeah. Well, I'm not seeing any other questions. Jane, do you have any other questions for me?
Mm, I just wonder what could we possibly do to incite getting better long-term, randomized prospective studies done
I
on
think we
viewers.
have to do a lot of work at rebuilding the NIH.
Yeah. And also
Um,
with a lot of these meds, these good meds being generic now, it's,
yeah,
the patches, it's really unfortunate that the way things
yeah,
evolve seems to be that if something's, a brand name, then it's going to get more support
right.
for that kind of thing.
Yeah, no, the drug companies have no incentive. They're not making enough off of these drugs to incentivize them doing studies on them. And I've seen that over and over again. Like I've been trying to convince Bayer to do um, a study on Mirena from years 5 to 8 as a counter to hormone therapy because we have no data there. And they're like, yeah, it's generic. I don't think that's going to happen. They're like, we can already sell it. So, like, okay. Um, Emily, thank you for your comment. N of one patient with heterozygous thrombophilia and history of DVT, 4 months into Linquet and micronized progesterone and doing amazing. Yay! Any updates on E4 OCP and VTE? No updates over what we already knew. So we're talking about Nextstellis here, which is estetrol and drospirenone. Certainly, all of the data points to it having a lower clot risk than ethinyl estradiol plus drospirenone, so the Yazes of the world. Um, and we don't see a lot of increased DVT risk, but I don't know that we have enough data yet to say it's comparable to transdermal. I know Mitch Crennan, who's done a lot of the work on this, is continuing to look at that and has definitely feels like the risk is very, very low. So more data to come, I think, on DVT risk and estetrol. And then is Divigel comparable to patch in terms of risk? Yes. Any transdermal form. Patch, gel, spray, femring. Never forget our friend the femring. Love the femring. Nobody can get it covered, but it's great.
Yeah, it's a good way to get estrogen in when people can't seem to take it or don't
Yeah,
absorb it well transdermally.
absolutely.
And
Any
since you were
update on when
talking,
E4 will come out for MHT? No, I have heard nothing from them. They did sort of their pivotal studies submitted to the FDA. The FDA required more data. And we haven't heard since. So I'm hoping we'll hear something within the year.
since you were talking about clot risk, what about the NuvaRing? Since I know it's obviously birth control level of hormones, but it's being
Hmm.
absorbed transvaginally. So
It
I'm
is,
not,
but it's ethinyl estradiol.
yeah, right. I'm
Ethinyl
not saying,
estradiol absolutely increases clot risk in all its forms. And we thought that the birth control patch would have a lower risk, and it doesn't.
mhm.
If anything, it was a little bit higher, although the lower dose patches may not do that. But I think ethinyl estradiol, it being ethinyl estradiol, trumps all, just because of the potency and the strength and how it binds. We always see increased clot risk with EE.
Good to know.
Yeah. Somebody's asking about Menostar, which I didn't
Mm.
even realize was still on the market, but it is. Would the risk for
Oh,
DVT be similar with Menostar, which is, for those who don't know, a 0.014 patch, which was designed specifically for two reasons. To look at for bone health. So, and they do have pretty robust data for even at that low, low, low dose protecting bone health. And it was designed to be the patch you could use without a progestogen. And per their data, they showed very little endometrial growth, and it is considered safe to use without a progestin. I will say that any of these studies, however, are at most 12 months long. So if you're going to have somebody on this for 5, 10 years, you might want to think about an occasional withdrawal bleed. So, in the N of one patient I have on Menostar, because I have one, I have her every 6 to 12 months. do 12 days of micronized progesterone at 200 milligrams and see if she bleeds. Just because I feel like I have to do something because we don't have long-term data.
So that's how you do the withdrawal bleed, is with 200 milligrams for 12 days
Yeah. Yeah.
of micronized progesterone.
Yeah.
Oh, good to know. So could you address the patch, the scarcity of patches? Has that gotten
Oh,
relieved?
it seems to be a little bit better. Just in the last like 2 weeks, I've had fewer patients writing in and asking how to switch or where to go. That may partly be because patients have realized which pharmacies have it or are just calling around themselves now because everybody's heard. But
Mm-hmm.
it just seems to be easing up a little bit. Um, the complaint I got today from my patient was that she can't get her myelin patch. They only have the dotty and she prefers the myelin. And I said, well, that I cannot fix for you. At least you can get a patch.
Mm-hmm. Yeah,
So,
good to hear.
all right. I'm just checking the Q&A in the chat one more time for any questions, but I think we're going to close it out there. Jane, thank you so much for doing this with me tonight.
Oh,
This was
it was
fun.
it was it was a great pleasure to look back through some of the information too and
I know.
sort of reacquaint myself with the whole idea of what these thrombophilias are and what they can do.
Yeah, no, and it's an area where we absolutely need more data. I am willing to be proven. I would love it if we could prove that these women are safe to use transdermal estrogen. It would make all of our lives easier. I just
Mm-hmm.
want more than what we've got before I can tell a woman it's safe. I'm not saying I won't do it, and I'll tell her what data we have, but we just need to be in our counseling very cautious with these women because their baseline risk is higher.
Yeah, and especially since it could translate over into also stroke and heart
Hmm.
attack as
Right,
well as
exactly.
DVT. So
Yeah.
those are not things we want to provoke.
No, no, we do not. All right, everybody, have a great night. Thank you for hanging in with us for this talk, and this will be available on video, so please share it out. One last piece of information. So you may have seen, if you saw the announcements for this is going to be the last of these webinars for a couple of months. Not because I don't love doing them, not because we're not going to continue to do them. We're taking a pause for two reasons. One, I want to reformat a little and think about future topics. But two, and more importantly, we're actually looking into how to get CME credit for these. And I have to do a major reformat to meet criteria for that because I'd love to be able to offer everybody CME credit. And wouldn't it be great to get an hour of CME credit every month for listening to these? So give me a couple
Sure.
months. We will be back.
Great. Thank you for doing this, Rebecca. It's very helpful to hear you analyze these complicated studies, put them, make
All right,
sense of them.
everybody. Have a great night. Bye bye.
Bye-bye.